Yeah, so everyone wants to improve the outcome of her or his patients, and there are some critical points which are very important to improve this outcome. Actually, one is okay. And the second thing is to have the best waveform, as we saw in the talk from Simon before. It's hard to find the best waveform for the patient or the best waveform ever. The third thing is that we want to have a low energy consumption to make it easier for the patient. And of course, the settings should be simple for the patient and simple for the technician as well, no matter whether he's experienced or not. So there are several studies concerning the best waveform that we can get. As you saw in the talk before, every study has points and limits, and so we still don't know exactly which is really the best waveform. So actually there's no gold standard so far. What should we do with our patients? What kind of simulation should we offer to our patients? One thing is that solely or only tonic stimulation is not the gold standard anymore. We know that there are better waveforms than tonic stimulation, so to work only with tonic stimulation does not make sense anymore. But on the other hand, there is no single waveform which is the only truth, which is the standard for patient groups. Even if you look at one single disease like failed back surgery syndrome or CRPS, you can't really find one waveform which is always working for the patient. So I think the optimal therapy means that we need an individualized treatment for every patient with an individualized waveform. So we have a standard in our clinic in our department to make the simulation, to program the simulation for each patient. Every patient gets an intraoperative mapping, if it's possible, to do it with the patients, and if the patient is compliant enough. And then we start with a burst simulation because we have a low energy consumption. We have no paresthesia. It's easy for the patient. He doesn't feel, he or she doesn't feel anything. And if this does not work, we tried now since 1.5 years, since we are implanting the contour, the wave writer, and then afterwards the alpha wave writer, we do the contour simulation algorithm. And if this does not work, we work with a combo stimulation with microburst and tonic stimulation. The contour simulation, as you have been told in the talk from Maxime already, is a simulation which is special because of the very broad field. Like the field spans multiple vertebral bodies or vertebral levels, and so you have a big field, and to find the right simulation or the right simulation point is very easy because you just program it and it works. You always work with 200 Hertz and make a sub-threshold or sub-perception simulation, and you try to, the dorsal horn is modulated, so you have a concentration on the dorsal horn with this simulation type, and the simulation, or to program the simulation, is much easier than with a simple bipole, like 8mm bipole, where you have to find the right spot, and if there's a lead migration, you have to find it again, because the field is that big that you don't have to change the place of the simulation anymore. I'm sorry, this is always a little bit delayed, so I'm a little bit delayed as well. The contour simulation itself is very simple. I think it is very effective and efficient, and And we know that, or we already heard in the talks before, that you can find multiple subperception sweet spots, like 3 sweet spots, program them, and they are working, and then you have a very, very big field of simulation. We know from the last talk from Simon that the HALO study showed the very good effect of this simulation type, and we know that the charging, or you have to charge less than with a high frequency simulation, of course. So to use first the contour simulation is easier for the use of the patient, and so we don't start with a high frequency first of all, and we tried with the contour simulation. Since we had since we are implanting the WaveWriter and then the alpha WaveWriter now, we had 69 patients who have been trialed with tonic, burst, and high frequency simulation. 56 of these patients responded, like 82% responded usually to burst simulation, and we had 13 patients who were not non-responder, and in this case we tried the contour and the combo algorithms, and we had like half of them, or 54%, changed from non-responder to responder. So we had a very good response actually, and a much higher responder rate in the end, because we could improve the responder rate from 82% to 94%, just using these waveforms additionally. I would like to show you one example case, one case study of this young woman. She's 35 years old, a female patient. She had an ankle trauma and CRPS afterwards, with a burning and a feeling of heat in her foot. She received painkillers for 7 years without any effect, high-dose opioids. She received already a spinal cord stimulation therapy without mapping and high-frequency stimulation. And finally, she received an amputation of her foot. But this didn't change anything. She had the phantom pain afterwards, which was pretty much the same as with the CRPS. And so she was even doing worse without the foot. And now the plan was actually to explantate the old device and try a new trial with other waveforms and with a mapping. In this case, we used, or I always use, in the Infineon lead with 16 contacts. Usually one lead is enough, I think. And we implanted the Spectra WaveWriter, and the lead placement was at T12 to L1, so it was very low. But the mapping was good intraoperatively, and we started with a burst simulation. We could not really significantly reduce the pain from 8 to 6, a little bit at least. And then we tried with tonic stimulation, also to make it more noticeable for her, because she didn't feel that there's any stimulation in her foot, and we wanted her to feel the stimulation for for 2 days. And with this simulation, the effect was a little bit better. And then we tried the contour algorithm with her, and the NRS was decreasing to 3, and so the result was good. The trial was successful, and we could go for the perm. And the programming was like that, with a standard contour algorithm, 200 Hertz, 1.2 milliampere, which is low and is enough for her and for other patients, for many other patients as well. And this is one example field. You can put several fields, like 3 fields, in for the simulation. The outcome of her was very, very good. So I was very satisfied in this case, but it's only 6 months, so I can't really say how the long-term outcome is. But in the six-month outcome, she was decreasing to 3, and she's still there with her pain, despite of reducing painkillers. She has no opioids anymore. She was, I have to say, in the beginning, not on a high dose opioid level anymore, because they already reduced it because it was not working. Now she's reducing the pregabalin, and her sleep is better. So we always use the Pittsburgh Sleep Quality Index. It was increasing from 10 to 17. She sleeps pretty well right now. Functionally, it was very important for her because she now can fit the high-tech prosthesis and can start to walk. And the programming with the control algorithm is still the same as I showed you before. So to conclude, my opinion concerning the contour algorithm is it the best waveform? I don't know. I don't think that there is a best waveform, but it's a very good, but I see a very good effect in believed to be lost cases. And I didn't try it in the first line because we didn't want to implant the wave writer at this time, because it was not MRI compatible. Now we have the alpha wave writer, and we are implanting always the alpha wave writer. And so we start to generate new data, and then we will see what kind of simulation is really the best for the patients. With the old device, I tried to implant the MRI compatible devices. So it was a bit special over the last year, and since 3 months we are using the alpha. It works not only for CRPS or phantom pain, it works for fade back surgery syndrome pretty well, for back pain pretty well, and other neuropathic pain syndromes. We have an increase of our responder rate, which is very important, of course, and we have a lower energy consumption than using high frequency simulation. And the setting is very simple for the patients, and the setting is very simple for the technician as well, which is also very important in the setting, I think, because otherwise you have a lot of work after implantation. Thank you very much, and I'm very sorry for the inconvenience concerning the technical things.